Good afternoon. I'm Michelle Mathis, Executive Director and co-founder of Olive Branch Ministry, a faith-based harm reduction agency that covers 10 counties in the Foothill Piedmont area of North Carolina. To give you kind of an idea, we go from the Tennessee-Virginia border down to the South Carolina border. There's almost 2 hours and 40 minutes from our northern tip to our southern tip of the geographical area that we cover. And I say that because all but one of our counties is considered rural in where we serve. So there's a lot of distance, but there's also a lot of communities that we cover with harm reduction services. For those of you who may not be familiar and may need a brief recap, harm reduction refers to policies, programs, and practices that aim to minimize negative health, social, and legal impacts associated with drug use, drug policies, and drug laws. It's not just day-to-day operations, but it is also a social justice movement, really centered on the rights for and the voices of people who use drugs and who engage in sex work. And I think that's super important, that meaningful engagement with people who use drugs is really key to harm reduction. And there's a lot of different ways that harm reduction is carried out. Things like syringe access, overdose prevention, MAT, medication-assisted treatment, medication-assisted recovery. That also is a form of harm reduction, as well as being able to treat people for different types of diseases. Housing first, wound care, things of that nature. And every harm reduction agency looks different. I want to talk briefly about what barriers we see here in rural North Carolina, rural Appalachia, to harm reduction, and then talk about how we have been able to cross some of those barriers or reduce them. The first one for us, as I mentioned, because of our geographical coverage, is lack of transportation. We have 3 fixed site locations. They're an hour apart from each other or more. So if you think about that. If someone doesn't have transportation, and in many of our rural counties and rural cities, there is no public transportation, that then requires mobile volunteers to be able to go out and deliver services. People can't walk, if it's an hour by car, they can't walk to where we are. And like I said, most of the time a bus or even an Uber is not available. We have higher poverty rates in rural Appalachia. And so that prevents people from being able to seek other types of care, maybe be able to go to a local pharmacy to purchase syringes if they're lucky to find one who will sell them syringes. The higher poverty rates also is a barrier for people receiving regular medical care, being able to receive things like food, clothing, shelter. Because we are rural, we have a lack of anonymity and confidentiality. And by that, I mean our programs in North Carolina, you can enroll in syringe access and be anonymous, and we do keep our information confidential. But when we're doing rural outreach, everybody, including their mom and them and their neighbors, or maybe community leaders, know who pulls into your driveway. They know if you're meeting somebody in a fast food parking lot or in the parking lot of a big box store. Everybody knows everybody in these little communities. And so you're never without a set of eyes possibly seeing what you're doing. And once somebody knows that you're a harm reductionist or knows what you do, then they make assumptions because of the shame and stigma on why you're meeting with a particular individual. We also, as I believe Dr. Levine and Dr. Cooper mentioned, we have a low health literacy in rural Appalachia, and there's a lot of cultural bias against brain health treatment. I say brain health because we don't have mentals, right? We have brains, and this is a physical disease that affects our brain. So that plays into people not wanting to seek care, people not understanding truly the ramifications of not seeking care. And then the cultural bias. Well, you should be able to do this on your own. We're tough. We've survived so many things. We should be able to do this by ourselves. And so that shame and stigma around people actually seeking care is a challenge. Then we also see In faith-centered communities, because again, we're in the South. And so a lot of our rural communities, their communities are centered on, certain faith beliefs. So we have the moral issue that is a barrier to care. Is it a moral failing, or is it scientific as to why people use drugs and then become at risk of things like HIV and HCV? That then in turns to a barrier of the conversation around enabling. Are we enabling people to continue in what is perceived a negative lifestyle? And then finally, unemployment or non-standard working hours makes it difficult to receive care. If you're unemployed, again, that plays back into poverty. But if you have non-standard working hours, if you're working third shift and you're sleeping during the day, then that may be a problem. Or if you're working, during the day and you're working a 12-hour shift, you may not have availability to seek harm reduction services because they may be only open during standard business hours. So we have a lot of different barriers that play into why people can't access harm reduction services. But we also have some solutions. I will share with you what we've done at Olive Branch Ministry. The first thing we like to try to do is think outside the box. We realize that the faith, for us, even though we're a faith-based organization, we say faith is our why, it's not our what, so we don't evangelize. We simply let our faith be our motivator as to why we do what we do. But we know that that's a tough conversation to have with folks around faith and handing people syringes at the same time, or providing overdose medication even. So we partner with groups like the Humanist Alliance, or with the local Atheist Association, and they actually have partnered with us and are some of our biggest supporters. And that has been really helpful. One, because there's stigma against us as a faith organization. People may not trust us, but that has helped kind of change the way that our community sees us. But it also then allows folks to have access to our services without that having a theological conversation, right? They know that that's possible to access our services that way. Then the stigma and negativity around syringe access programs. Olive Branch was doing syringe access underground for a number of years, as many of us in North Carolina were, before it became legal in 2016. We had agencies that would partner with us and allow us to use an office. For example, we had an MAT clinic who said, we know what you're doing. We can't acknowledge what you're doing, but we support your work. So we're going to give you an office and you can hand out naloxone. But what we want you to do is everybody that walks into that office, you shut the door and everybody walks out with a brown bag. We're not going to ask what's in the brown bag. Our staff is not going to ask what's in the brown bag, but we want to support you in the work that you're doing. And so that was a very unusual partnership to have with an MAT clinic who knew that we were actively engaged in syringe access. Then we have naloxone, and trying to get naloxone to folks and making sure that they have access to that to, be able to reverse an opiate overdose. So we partnered with a local crochet group who makes these beautiful little crochet bags that have reflective thread in the handles. So people can find their naloxone without electric light. They, find it in the moonlight if they need to. This is an unusual partnership, but it accomplished of bridging the barrier between naloxone access actually and also the faith community, because the women who make these bags really weren't wanting to work with individuals who use drugs directly, but they still wanted to help in the process. So it began to start a conversation. And now they ask all the time, have our kits saved anyone? We partner with integrated care clinics. So 2 of our clinics are literally between outpatient counseling services and detox. And we're very much included in the continuum of recovery because of our location. When someone comes out of detox, the first thing they do is get naloxone, and we're able to refer people to detox if that's what they want, or rehab, or to outpatient therapy. We have a peer support that's in an MAT clinic as well. Finally, I think it's important to know that at Olive Branch, one of the things that we recognized specifically around hepatitis was the fact that because of transportation, because of all these barriers I've listed, people could not get to our clinics, but they also couldn't get to a medical clinic. And we have a nurse practitioner who volunteers with us, and he's employed by the federally qualified health clinic in a neighboring community. He's volunteered with us for quite a while. So back in February 14th of 2020, last year, we started a low barrier Hep C testing and treatment program. Since that time, we have engaged 93 individuals. Of those, 74 engaged in actual treatment. We lost a few to care. Unfortunately, we lost a few to overdose. That's a 73% success rate in getting people either they've been cured or in the process of receiving a cure. And we did that by going into people's homes, carrying food into their home, and also testing there. I think that's really important as I wrap up, just to say we meet people where they are in harm reduction, but we literally are carrying the treatment and the testing and the treatment where they are. And that's one way to eliminate the barriers, really, is to carry as much of your services out into the field as possible. Thank you.
Thank you.